pulmonary hypertension. It's good that you had a nice mental break with procedures. That was fun because if last lecture was like the most straightforward, this one gets a little complicated with congenital disorders because there's a lot of stuff where there's shunting and the circulation's different in fetal circulation versus adult. So everyone put on your thinking caps that have been on for actually quite some time now. It's like second semester. But we're going to talk about some physiology of fetal circulation, what's normal, and then we're going to talk about certain type of congenital heart diseases. You guys had peds already and touched upon some of the common congenital stuff. Okay, so it's good. It's not the first time you're going to hear the words like shunt and all the tetralogy of Fallot and stuff. Excellent. We'll just go into a little bit more detail with this. So congenital cardiac abnormalities are the most common birth defects in humans. There used to be not like when someone was born with these types of abnormalities, there wasn't a lot of treatment. Today, there are much better mortality rates due to advancements in procedures and technology, and more than 85% of infants who have some congenital cardio anomalies now can expect to reach adulthood, which is really revolutionary. They can do crazy stuff intrautero once the baby is born. Pediatric cardiothoracic surgery is very, very specialized now. Some of these diseases can go undetected until adulthood, and some are detected either before birth when you're getting the ultrasound on the mom. You can see some of these abnormalities, and some of them are present at birth or a couple months afterwards. That is how the boards likes to give you clues with congenital abnormalities is when they are presenting. So like we're going to talk about the two categories of acyanotic and cyanotic congenital lesions. And usually acyanotic may not be present at birth. It may be like a couple months later, whereas cyanotic will be present like immediately after birth. And that's going to help you distinguish like in a clinical vignette. And also if you go into pediatrics, how you're going to diagnose them. If certain diseases, like I was in adult cardiology, so I would see some congenital stuff that would present later in life, like people can have VSDs, ASDs, PFOs, and they're asymptomatic until someone does an echo in adulthood or they have a complication from that. So I would see those usually if someone has a congenital defect at birth and they need like a surgery or something, pediatric cardiology will follow them for their whole life. So even when they're adults, so they wouldn't come to us. They like really keep their own chicks. Tips for evaluating congenital heart disease. So like I said, we're going to understand and review normal cardiac anatomy. When there's one congenital finding, look for others because sometimes they can clump together. They could be a syndrome. They could be a sign of another genetic disorder, not just isolated. We're going to evaluate the reason and the degree of left to right shunts and right to left shunting. We're going to define pulmonary hypertension. And then we're also going to talk about whether the congenital problem can be fixed, surgically corrected, or just treated. So how much do you guys know about shunting? A lot? A lot. Everyone's like, well. All right, so we'll redefine it. We'll just orient everyone on the same page. So when we talk about shunting, it means that there's a communication between two cavities. So it could be the right atrium, the right ventricle. No, that's the normal one. Right atrium, left atrium, or two of the ventricles. Shunting tells you which way blood is flowing. So say there is a ventricular septal defect, which is a hole in between the septum of the ventricles in the heart. Whatever pressure is higher, right? The blood wants to flow from high pressure to a lower pressure. So which side of the heart typically has a higher pressure? The left side. So if somebody has a left to right shunt, that's telling you that the pressure is higher in the left ventricle and it's flowing into the right ventricle. So that's oxygenated blood flowing into deoxygenated blood, which initially won't really cause as severe of problems as the reverse, right? Because if deoxygenated blood is mixing with, oxygenated blood is mixing a little bit with deoxygenated blood, okay, you're going to have more oxygen on the right side of the heart and you're going to have a little bit more volume of blood on that side. Whereas if you had shunting from right to left, you have deoxygenated blood mixing with oxygenated blood, diluting the oxygen that's supposed to be perfusing all of your organs. So usually you'll have symptoms of possible cyanosis, shortness of breath when you have right to left shunting. The tricky thing is some of the left to right shunts can flip to right to left shunts. If the pressure over time becomes higher in the right ventricle, so are you guys following? Or is everyone like, today's my last day? Okay. So the extra pressure and volume in the RV can cause changes, right? We talked about compensation and heart failure, that the heart can remodel to compensate for inappropriate blood flow and mechanical things that aren't working. So if there's more volume in the RV, chronically higher pressures in the RV can cause remodeling where the RV gets thicker. Then those pressures ultimately can back up into the pulmonary circulation and cause pulmonary hypertension. So now we have chronically higher pressures in the RV. And when those pressures become higher than the LV, the blood starts flowing right to left. And that's when we have problems. Does that make sense? That's important to grasp before we go on our journey of congenital heart defects. Because we're going to be saying left to right, right to left, with defining a lot of these. So left to right is better for patients. Right to left is more concerning. Okay, so we're going to review normal adult circulation, which we know already. But just because we're about to flip this whole circulation when we talk about fetal circulation, let's just go through it as a reminder. So we have deoxygenated blood entering the superior and inferior vena cava into the right atrium. Then that deoxygenated blood moves through the tricuspid valve into the right ventricle, out of the pulmonary valve and into the pulmonary artery, which goes to the lungs. We take a deep breath in and we oxygenate our blood through the capillaries. That comes back to the left side of the heart through the pulmonary veins, into the left atrium, left ventricle, and out through the aorta to the rest of the body. Also in the children's book I have for my daughter, she just learned this part too. It's like it goes through everything with like the bump, put your hands over your heart. This is the right ventricle. And then it says, take a deep breath in, and it goes through that. And she goes, and I'm like, fake news. Okay, so that's adult normal circulation. Fetal cardiac development, and then we're going to talk about fetal circulation. So the heart formation begins during the 3rd week of in utero development. So 22 to 23 days, the primitive heart starts to beat. And this is what it looks like first. It's kind of just like it starts off at like 2 tubes on after 20 days. They fuse together and then they can start beating around this point. And it kind of like folds and twists in itself. And then this breaks out into the right atrium, left atrium, and the ventricles. And at 28 days, it has 4 chambers, which is wild. And then at 8 weeks, you see this resembling much more of a human heart now. So to understand fetal circulation, we have to understand the way that circulation is bypassed. So the placenta basically does all of the work for perfusion in the fetus. So how the blood flows is the placenta to the umbilical vein. It goes through the circulation that we're going to talk about, and then it comes back, deoxygenated blood, through the two umbilical arteries. Okay, so stay with me because this took me a lot of YouTube videos to get in your head. It takes a lot of time to reverse everything that we just talked about in adult circulation. So if the placenta is here, the oxygen-rich blood from the mom's placenta comes through the umbilical vein. It bypasses the liver, and it dumps the oxygenated blood into, where is this? Right into the left atria. I'm sorry. So the umbilical vein dumps the blood through the inferior vena cava, which goes into the right atrium. There's a communication between the two atria called the foramen ovale. So this connects the right and left atria via a little flap and allows the circulation to bypass the lungs. So we basically aren't really using the whole right side of our heart, and we're not using the lungs, we're not using the liver. So through the foramen ovale, the circulation goes out through the left ventricle and into the aorta and perfuses all of the organs of the baby. The ductus arteriosus, then it comes back through the pulmonary vein. It bypasses the lungs, and the deoxygenated blood enters the aorta again through the descending aorta, and this goes back through the ductus arteriosus, and this goes back through the two umbilical arteries with deoxygenated blood back to the placenta, and then the cycle happens again. So we're not using the baby's lungs yet, right? Because they're filled with fluid. They're non-functional until the baby takes their first breath. We're not using the baby's liver. And we're really not using the right ventricle for deoxygenated blood. Everything's happening mostly through the left side of the heart. So the fetuses have ductus venosus, again, that bypasses the liver, that brings the oxygenated blood to the heart. The foramen ovale, which allows that oxygenated blood to enter the left side of the heart, and then to the aorta where it perfuses everything. And then the deoxygenated blood also mixes with the aorta and comes back to the placenta. So this allows the growing fetus to receive circulation from the mother. What's that? Pulmonary artery. So after it goes to the aorta, yes. So blood mixes via the patent ductus arteriosus. So there's a connection between the pulmonary artery and the aorta. Everyone with me still? So how's the blood getting into the right ventricle? So it's kind of split in two ways. So when the oxygenated blood goes through the inferior vena cava into the RV, and then it enters through the RA, through the left atrium, left ventricle out to the aorta. As for the deoxygenated blood, so once it is, let's see, so it mixes through, it looks like it mixes through the umbilical vein. Let's see. There's mixing of blood here. So some of the deoxygenated blood is coming back to the placenta. But I see what you mean. So there's blood that perfuses the lungs in here, but that's all it's doing. Like it's not, the whole right side basically is not working for that. So the superior vena cava is what is accepting deoxygenated blood, and that is entering the pulmonary artery, and then it mixes with the oxygenated blood that's perfusing, and then it comes back down.
How does it get from the pulmonary artery to the aorta? Because wouldn't the aorta have higher pressure?
So not in a fetus. It's a slower flow because you're right, the pulmonary artery has a lower flow because the higher pressure is in the aorta, but there is a communication, and because there's a communication, there's mixing of the blood there. That's a great question. So 3 bypasses. We're bypassing the liver, the lungs, and pretty much the whole right side of the heart. Yeah. So from the left atrium, yep, it goes to the left ventricle and then out the aorta.
Where is it? Up to the aorta, comes back through the aorta again.
It comes back through the superior vena cava after the oxygenated blood has been used. So also to the right atrium. Through the so from the right atrium, it goes out through the pulmonary artery into the communication with the aorta, to the descending aorta, to the umbilical arteries, and then back to the placenta, so the mom can reoxygenate it. It's gonna take a couple times to like spend time. It's like, this is like EKGs where like I say it and you guys are like, yes, and then you review it on your own and you're like, okay. It takes a couple times. So then the transition from fetus to neonate, the baby's first breath shifts everything. So with the mechanical inflation of the lungs, peripheral vascular resistance falls and pulmonary vasculature dilates and the fluid leaves the lungs. So what happens to the ductus venosus, the foraminal valley, and the ductus arteriosus? So the ductus venosus is going to close as the umbilical cord is clamped. Then fibrin will fill in the vessel and it'll just become a ligament. For the foraminal valley, this flap will close as the right atrial pressure drops below the left atrial pressure. The ductus arteriosus, this is the one that connects the pulmonary artery to the aorta. This will constrict in response to increased oxygen tension. So these should close within like the first couple of days of birth.
They don't close right away.
They may not close right away. So that's what we're going to talk about. Those are part of some of the cyanotic lesions is when they don't close.
So you're saying it's normal how to do it, they close it in a couple of days back. So after those first few days, are they able to
So the pressure is higher in the left ventricle. So even if they have like a very small communication, if they have left to right shunting, it won't really cause any symptoms at first, and then it'll close and everything resolves.
Mostly different kind of one. Chunk,
I guess you could think of it like that. So our acyanotic congenital defects are patent foraminal So when the foraminal valley stays open. Atrial septal defect, that's a communication between both of the atria, but that's like a true congenital lesion because it's not that something in utero stayed open. It actually shortened when the heart was forming, the wall shortened and it didn't close. Ventricular septal defect, same thing as atrial, except it's in the ventricle. Patent ductus arteriosus is when there's still that communication from the aorta into the pulmonary artery. And coarctation of the aorta, you guys have heard of that in peds before. That's when like one part of the aorta is like cinched and narrowed. These will typically have left-sided oxygenated blood to right-sided shunting of circulation. So that's why they're called acyanotic congenital lesions, because they don't cause cyanosis ever. So for the foraminal valley, again, there's right to left shunting in utero. If it remains open, you'll have a left to right shunt, right? Because as soon as the baby takes its first breath, the pressures in the right side of the heart lower, and now there's left to right shunting if that communication stays open. Usually this closes within 3 months due to left atrial pressure becoming higher than right atrial pressure. And in about 20% of the population, it just doesn't close. It'll stay open. And a big chunk of that population is asymptomatic and has PFO and they don't know it. Let's see. So this is just a little diagram of the shunting in foraminal valley. This kind of shows you what happens after the baby's first breath. So there's right to left shunting in utero, and then once the pressure switch, the PFO has like a little flap and it seals it shut. So commonly, like you may not even detect this on echo if it's a flap, because it may be shut and then it opens at certain times. So again, like 20 to 25% of the population has this. This may be an innocent finding on just a routine echo. It can be silent and undiagnosed for years. Commonly, if we do find this, it's found as a part of a cryptogenic stroke workup. Do you guys know what a cryptogenic stroke is? So cryptogenic just means there's no other reason for the stroke. So if there was like, if someone comes in with a stroke, usually specialties are called in to figure out why the stroke happened. So neurology will do a scan of the brain and they'll see, is it embolic? Is it hemorrhagic? Is it ischemic? And then if they determine it's embolic, they'll call cardiology in and say, where did the embolism come from? So things that we know can cause an embolic stroke are AFib. So if there's no documented AFib, or if there wasn't any like plaque in a major artery and we can't really find a source, or there wasn't like an atheroma somewhere that could have broke off, they will call it a cryptogenic stroke. And then we go on a wild goose chase for a PFO, which is usually part of the workup for a stroke. And we check for this communication. So this would be caused, usually the PFO can cause a stroke from the venous side. So a lot of times we'll see a patient will have like a DVT and a stroke. And that wouldn't make sense, right? If it's a closed circulatory system, the right side of the heart shouldn't be mixing with the left side of the heart. However, if there's a PFO, a communication between those sides, that clot could very well move up to the heart and travel over to the left side and cause an embolic stroke. if there's temporary right to left shunting. So we talked a little bit about chronic elevated right-sided pressures over time that can switch the shunt. There's also certain metabolic things that can switch a shunt in a patient that has this. So say someone has a PFO and there's left to right shunting on echo, which shouldn't cause any type of embolic venous event. But say they have sepsis and temporarily the right side of the pressures of the heart go up and the shunt reverses. That can cause a PFO stroke. So in summary, sometimes this is found randomly, sometimes they present as a cryptogenic stroke. And how we diagnose this, a transthoracic echo on its own is not enough to make the diagnosis. We want to see the shunting. You usually need a transesophageal echo or a bubble study. And a bubble study, do I have this? No. So a bubble study is when you do a regular echo and you literally inject a little bit of saline into the patient and you wait to see if the bubble passes from the right atria to the left atria, and that'll confirm a PFO. How do we treat this? Normally, if it's small and if it's either an innocent finding or the first time they had a stroke and they're a certain age, you can just treat it with antiplatelet therapy, aspirin or Plavix, or anticoagulation. If they meet criteria to close it, we close it. So the decision to close the PFO depends on the following factors: age, so less than 60 years old with no other identifiable stroke identified. So if they have AFib and a PFO, you're going to anticoagulate them first before we go in and fix this. We have to determine if it was truly an embolic event. The size of the PFO has to be a certain size to be able to close it, and the shunting size. If it's large, and there's shunting between the atria, this will cause symptoms and problem over time, just like we talked about. And usually the PFO is not really associated with shunting because it's small. And it's commonly over-treated. So over-treated means if you find somebody that has a PFO that may not be causing any problems, but they found it in the midst of a stroke workup and they closed it. Sometimes if you don't truly know the origin of the stroke, it may not be indicated and it's over-treated in that way a lot of time. Yeah, so that's a great point. So there's always a risk to every procedure that you do. So anytime you're doing a procedure, you are sedating a patient, you are putting them at a greater risk for infection and complication, and you're essentially sticking a wire into their heart and putting a patch there. When you put the patch in, you have to be on antiplatelet therapy for life. You have to be on aspirin for life, otherwise it can clot up. So those are the risks you have to know are worth it to take if you are fixing someone's PFO. Okay, any questions on that? Yeah.
Even if like,
You would get an interventionalist to evaluate the PFO size and criteria, but always put them on either antiplatelet or anticoagulation first. So for the next acyanotic lesion is an atrial septal defect. So this is a true structural defect.
figure would be.
And
Sorry, what'd you say?
first line, if you really do.
No, opposite.
Only patients that are not.
So you evaluate everyone if they're a candidate for closure, but usually it's a very specific size and shunting criteria if they are. If they don't have the shunt size, if they're not under 60 years old, you're going to put them on antiplatelet anticoagulation. Is that clear? Okay. So tricky because like this is when we treat PFOs, there's this whole algorithm, but this could be like a whole course in itself, but we only have 2 hours, so I got to cram it in one slide. So if anything's unclear, just let me know. So an ASD, like we said, is a true structural defect, and this is caused by failure of fusing to the atria septa while in utero. So you can sometimes see if someone has an ASD if it's big enough in utero. This may cause shunting of left side to right side. That could lead to RV overload and remodeling over time. If the right pressure eventually exceeds the left, it may cause cyanosis. But initially, this is usually an acyanotic lesion. And if it's small enough, this can also present like much later in life. So small to moderate size, usually asymptomatic unless a complication occurs. Large size may be present with dyspnea, heart failure, paradoxical embolisms, palpitations, recurrent lower respiratory infection. And paradoxical embolism is what we talked about, similar to a cryptogenic stroke, where something from the venous side switches over to the arterial side and causes a stroke. The murmur, your board loves this murmur, is going to be a fixed wide split S2, a mid diastolic murmur, and they may have an RV heave on exam if they've had chronic changes in shunting to that side. The EKG is going to show possible RVH, right bundle branch block, and right atrial enlargement if there is chronic shunting to the right side. So just to reiterate, what's the criteria for RVH? What's like the two things that'll look different? So that's right bundle branch block, right? That's the widened QRS and the bunny ears in V1. RVH would have right axis deviation, and then V1 and V2 would be the tallest, right? Because those are the right precordial leads. So that would be RVH. Right atrial enlargement, I would not hold you to that. The P wave is going to look a little, it may look biphasic and a little widened, but I would definitely know RVH, right bundle branch block. Diagnosis, we can do a transthoracic, a TEE, or a bubble study for this one. Right heart cath will assess PVR, so you will see a step up in O2 saturation from the inferior vena cava to the RA. And that makes sense when we think about it, right? So the inferior vena cava is bringing back deoxygenated blood, so it shouldn't have a lot of oxygen in it. And then once it dumps itself into the right atrium, it should be the same oxygen level. Nothing happened, it was just being dumped in. If there is a left to right shunt, the oxygen in the right side of the heart is going to be higher, right? Because there's oxygenated blood getting into the right side. So on a right heart cath, you will see that step up in oxygen saturation from the inferior vena cava to the right side of the heart. Does that make sense? And then treatment. So patients with small shunts can live normal lives with no intervention. You put them on a baby aspirin. And large shunts can cause disability by the age of 40 for those chronic changes that we talked about and need surgical repair or percutaneous closure via cardiac catheterization. So this is a picture of how they would surgically fix it. It's open heart surgery. They sew it back up. This is an interventional cardiac cath procedure where they put like a plug. They put a catheter through the ASD, and then they kind of pull the plug that adheres to the atrial wall, and they dislodge the catheter off the wire, and they leave that behind. And then they have to be on aspirin and Plavix, and then aspirin for life. Ventricular septal defect is the most common congenital heart lesion. Up to 20 to 30% of congenital heart lesions are VSDs. There's 4 different types. There's type A, and this just tells you where it is. Just know that type B is the most common. So membranous VSD is the most common, up to 70%. Membranous and muscular may spontaneously close in childhood as the septum grows, which is great. The less intervention, the better. Because this is an acyanotic lesion, this can present later in life. So this can present like 2 to 3 months of life. A small VSD usually has no symptoms but a harsh murmur. And a larger VSD may have more symptoms, but actually the murmur could be softer because the opening is wider. With a large VSD, you're going to have symptoms of heart failure, tachypnea, failure to thrive, poor feeding, and lower respiratory infections. And that will happen around 2 to 3 months of life. You'll start seeing those symptoms in the child. And this is because we keep saying the same thing, RV pressure overload from left to right shunting. Right heart failure is a late complication, and once it switches from right to left, it can cause cyanosis. And cyanosis plus pulmonary hypertension and an intracardiac shunt is called Eisenmenger syndrome. Any of them. So if any of those intracardiac shunts cause those things, the patient has Eisenmenger syndrome. And the murmur is going to be harsh pansystolic. The smaller it is, the louder it gets. They may have an RV heave with a systolic thrill. So remember in PD lab when we're like, when are we ever going to hear a thrill? This is the time where you could actually feel the thrill, which is like, feels like a cat purring. Common with this, and also common, you guys are going to feel this when you work in the hospital and you're on clinical rotations. If someone has a big dialysis fistula, you'll feel a thrill there too, because there's the mixing of the turbulent blood flow. So maladie de Rogier, I don't know why I put that in there. I don't speak French, but it means that the larger the VSD, the softer the sound because of the decreased pressure gradient, right? If there's like a smaller hole, the pressure gradient is higher. Like when you put your thumb over the hose and you make like a jet, versus if it's wider, there's less of a pressure gradient because of the mixing of blood. How is this going to present? Cardiomegaly on a chest x-ray with an enlarged pulmonary artery. Peripheral pruning. So this is when there's decreased pulmonary blood vessels seen due to pulmonary hypertension. So the pulmonary vasculature starts to remodel the smaller vessels because of these changes. The EKG, we're going to see, we may see LVH and left atrial enlargement. How do we diagnose this? You can see this on a regular transthoracic echo with Doppler. And then a right heart cath, we are going to see increased oxygen saturation in the RV compared to the RA. And that makes sense, right? Because the mixing of the blood occurs in the ventricle. So the blood that's being dumped into the right atria from the vena cavas is going to have a lower oxygen saturation than the RV, which is receiving blood from the left oxygenated side. Does that make sense? Excellent. Treatment. So by age of 2, 50% of small to moderate VSTs will spontaneously close, which is great. So usually if they identify someone has a VSD, they'll follow them with serial echoes until the age of 2 to give them a shot for it to close on their own. You can use medical therapy as a bridge to surgically correct this if it doesn't close or if it's large from the start. We're going to treat this with preload and afterload reducers like diuretics, ACEs, and ARBs, and nutritional support, right? Because this we saw if it's large can cause failure to thrive, heart failure symptoms, things like that. And surgical correction you're going to do if it's large enough or if shunting is present. And this is usually, this could be done transcatheterally, similarly to how the ASD was closed, or open heart. Patent ductus arteriosus. This is the communication that's normal in utero. So this was the communication from the pulmonary artery to the aorta. You have a question? It depends. Like, it depends on how sick the baby is. If the shunt is large enough that they are gonna spend time in the ICU, like as a neonate, if it's large enough that they're not gonna wait until the age of 2 to see if this is gonna spontaneously close. If it's large and shunting at birth, they're gonna be in the NICU and they are probably gonna get feeding that way. If it's more stable and this is being monitored and treated as an outpatient, they're probably just going to use certain formula or increase feedings and have them come in for frequent weight check to make sure that they're gaining weight. This question. So PDA, this is normal in utero, not normal if it stays open when the baby comes out. This is going to also be a left to right shunt, connecting the left pulmonary artery and aorta near the origin of the left subclavian artery. Risk factors for this staying open: if the mom has first trimester rubella, or if the baby is born prematurely, the normal growth of the heart comes out, the baby comes out sooner than it's like fully cooked and ready to come out. So prematurity and first trimester rubella make babies at risk for this. This is rare to have in adulthood. Usually there's no signs or symptoms unless there's LV failure or pulmonary hypertension develops. Small PDAs are asymptomatic, large ones, heart failure, failure to thrive, palpitations, dyspnea, lower respiratory infection. You guys are seeing like a pattern here, right? The small ones we leave alone, we can monitor, they're asymptomatic. The larger ones we usually have to do something about and causes shunting and further problems with remodeling. Your boards also loves this murmur. You guys have seen this murmur before, right? Continuous machine-like murmur near the left subclavian. That you're definitely going to see on your boards. Again, this one only becomes cyanotic if the shunt reverses right to left. We diagnose this with an echo with Doppler. If it's large enough with shunting and remodeling, we could see cardiomegaly, enlarged pulmonary vasculature from heart failure. The EKG may show LVH and left atrial enlargement. And there's a step up when we do a right heart cath and we check the oxygen saturation. There's a step up in O2 in the pulmonary artery compared to the RV. And that makes sense too when we think about the shunting, because blood is being shunted from the aorta to the pulmonary artery via that ductus arteriosus. Again, small ones close spontaneously in the first month of birth. Generally, this is medical management with indomethacin, used in premature babies and neonates. So prostaglandin, when the baby's in utero, will keep these, the ductus arteriosus open, and indomethacin blocks those prostaglandin synthesis. So it'll close via indomethacin sometimes because it can block that. Sometimes it needs surgical ligation. Coarctation of the aorta. This is a common cause if this is diagnosed, if it's like mild and it's diagnosed in adulthood, this is a common cause of secondary hypertension. We have a whole hypertension lecture in a little bit that we're going to talk about. I think like either the second to last or last one, but you guys have heard of secondary hypertension so far? So coarctation of the aorta is a common cause for that. So localized narrowing of the aortic arch, just distal to the subclavian artery next to the ductus arteriosus. And then there's certain types depending on where it's found, as you could see on this bottom diagram here. So like we talked about, if there's one congenital abnormality, you're going to look for other syndromes that it could be associated with. A lot of times, if you have coarctation of the aorta, bicuspid aortic valve is associated with this in like 50 to 80% of patients. Also associated with Turner syndrome. And it should also always be considered as a differential in young patients with secondary hypertension. How does this present? The theme is back. Can go undetected if it's mild until it causes hypertension in an adult. Can be associated with cerebral aneurysms. In less severe cases, asymptomatic. Severe cases, we have LV dysfunction and heart failure. This also your boards loves. So how you're going to diagnose this on physical exam is you're going to have weak or delayed femoral pulses. And that makes sense, right? Some of the aorta is kinked. So there's going to be diminished blood flow as you get peripheral. And you're going to have elevated blood pressures in the upper extremities. The blood pressure in the right will be greater than the blood pressure in the left. If the left subclavian compared, let's see, and in the right arm compared to the leg. Usually don't check the leg. I would just remember the right arm will be more elevated than the left arm. And also top to bottom will be a pressure difference. But when in reality, when you guys check a blood pressure in the leg, it's usually less because it's farther down. And depending on if the patient is obese and you don't have the right cuff size, it's not always like 100% accurate. The murmur you're going to hear is a systolic murmur heard over the back and the chest, or an aortic insufficiency murmur if they have a bicuspid aortic valve associated with it, because that can cause AI. You may see a webbed neck if they have Turner syndrome. So those are the clinical physical signs that you're going to look for. On chest x-ray, you may see something, oh, I'm sorry guys, the picture is blocking it off, but it just says that you're going to see something, you're going to have an indented aorta at the site of coarctation. You may see that on chest x-ray right here, where it's pointing to, so it's notched here. And you also may see rib notching. And rib notching occurs because the subclavian supplies the subcostal, supplies blood to the like the intercostal arteries. And if the rest of the body isn't getting enough blood supply distally, over time, the intercostal arteries will try to compensate that with collateral circulation through the ribs. And that over time will break down like the bone of the rib cage, and you'll see that on chest x-ray. The EKG may show LVH, and the 2D echo, if it's associated with the bicuspid aortic valve, may show that with aortic insufficiency. For this, an MRI and a CT scan with contrast is best. What's that? Yes, right here. 3 side looks like this, because that notch goes in, and that's the 3.
The rib notching?
It can be on both sides. And the treatment is prostaglandin infusion to kind of hopefully dilate that a little bit more, dilate the artery open. Excision, sometimes they try a transcatheter balloon dilatation to relieve the narrowing. 25 to 50%, even after you fix this, will still have hypertension if they have chronic changes from having high blood pressure. So if they still have LVH, they may still have hypertension even if you fix this. Okay, so those are the acyanotic lesions. In summary, they're acyanotic because usually when the patient is born, they will not be cyanotic, and they will typically have left to right shunting, which can lead to chronic remodeling and eventually become cyanotic if the shunt reverses and the pressures change. If things are small, we usually leave them alone and they spontaneously close over time in a lot of patients. If they are large and if there's significant shunting, that's when we intervene. Any questions on that so far? Yep.
So a little shunt is okay.
A little shunt is okay. Unless it causes a stroke. Excellent. Not excellent for the stroke, excellent summary.
Only to the left.
A little right to left is bad.
A little.
Exactly. Okay, so now we're in the cyanotic congenital defects. So these are the more severe defects that usually require treatment or surgical correction at birth. And these patients are going to present with cyanosis closer or around birth. And they typically will have right to left shunting or some type of anomaly where the right side is mixing with the left side. The most common ones that are definitely going to be on your boards are tetralogy of Fallot, which is the most common cause of cyanosis after infancy, or detransposition of the great arteries. So this is the most common cause of cyanosis during the neonatal period. More rare ones that we're going to go through, but are thankfully extremely rare, are total anomalous pulmonary venous return, tricuspid atresia, hypoplastic left heart syndrome, and truncus arteriosus. So tetralogy of Fallot has 4 main characteristics. The acronym VOR sounds like 4. So maybe, I'm not sure if that's a real acronym or I just put it because I listed them like that, but I hope that helps. And you guys you've seen this in peds already, right?
Yeah.
Just like a little bit. Okay. And intro to what? Excellent. Okay, awesome. So 4 main characteristics. Is not intro to sir? Or patho maybe, right?
Yeah. And
Patho.
Oh, yeah.
Yeah.
Because I remember Dr. Halimi was like, I had to, you guys didn't have it before you did it.
Yeah, it's a 2.
Yeah.
He was in
He was in.
All right, so the 4 main characteristics are you're gonna have a VSD, like we already defined, right? The communication between the 2 ventricles, an overriding aorta in 50% of these cases. So this means that either the aorta arises from the right side of the heart or it accepts blood from both sides of the heart. So usually the aorta should only be in the left ventricle, right? Usually the septum closes that off. So in this case, the VSD allows blood to flow into the aorta from both sides. So right off the bat, we have deoxygenated blood mixing into the aorta, and there is your cyanotic lesion, right? We have right to left shunting right from there. They will have RVH as part of the criteria. The RV outflow obstruction will also be present. So this is usually a subvalvular pulmonic stenosis. So the actual pulmonary valve won't be stenotic. There will be hypertrophy just below it. So those are the 4 main characteristics. And there could be like a bunch of variations, but these are the main ones that you have to know. So a little bit of pathophysiology about this one. We have increased resistance caused by the subvalvular pulmonic stenosis. So because the deoxygenated blood, like everything kind of perpetuates on each other. So because the deoxygenated blood is obstructed, the pressure is higher over here because it can't easily get out into the pulmonary artery. And also there's a huge communication with the VSD. So this causes shunting right to left through the VSD, resulting in hypoxia and cyanosis. The magnitude of the shunt is related to the degree of pulmonic stenosis. So the bigger the VSD is, the more severe the pulmonic stenosis is going to be. This will be identified at birth. So the clinical vignette they'll give you on your boards is they will present with TET spells at birth. So when the baby comes out crying, they'll turn blue. They'll have irritability, cyanosis, hyperventilation, syncope, and possible convulsions. Squatting will alleviate the symptoms because of pressure changes. And the murmur is due to the stenotic outflow tract. So you may hear a pulmonic stenosis-like murmur. The chest x-ray is going to show a boot-shaped deformity, like you see here with this boot for reference. And your EKG is going to show RVH and right axis deviation. The 2D echo can see the right flow, you could see the right outflow obstruction and the VSD, and that makes you suspicious of tetralogy of flow. So how do we treat this? These three surgeons, Balak, Thomas, and Tausig, I don't know which one is which, but these are them. They created this palliative procedure to help neonates survive this until they're old enough to get the major surgery to actually treat it. So you can see here, they create a left to right shunt to help cyanosis. So they put a communication between the pulmonary artery and the subclavian vein. This was actually developed in 1944, and this is used to help with TET spells and cyanosis while they wait for the more major repair. They usually use a patch to close the VSD, and they will open the pulmonary outflow obstruction to correct this. Okay, so if this is, let's see, they're making a left to right shunt. So in turn, they are trying to, even though this is still like half oxygenated, half deoxygenated blood in the aorta, they're recycling it back into the RV to slightly increase the oxygenated blood on the right side of the heart that's being shunted. And this is not like corrective, this is like palliative, and it just helps them get a little bit more oxygen to the rest of the body in that way. So they still may have some cyanosis because they have that shunt. This lessens it and decreases these symptoms that we defined before. So cyanosis with crying will be better, irritability, hyperventilation, syncope, and convulsions. It's not, this isn't a curative procedure, it's palliative procedure. Yeah, because you're closing the communication, you're stopping the shunt, and then they will do a surgery to relieve the pulmonic obstruction. Any questions on that one? Excellent. Transposition of the great arteries. So this is when the aorta and the pulmonary artery arise from the wrong place. They are flipped. So this is not compatible with life, right? If the aorta is connected to the right ventricle and the pulmonary artery is connected to the left ventricle, we're not getting oxygen in the correct spot. Severe cyanosis at birth will be present, whereas with tetralogy of Fallot, they may present with cyanosis like maybe a day or two after when they cry, when they're crying a lot, with TET spells, and then transposition of the great arteries, they are born cyanotic. If they don't have an interconnecting chamber to mix the deoxygenated blood with oxygenated blood, like if they don't also have a VSD or an ASD, this is incompatible with life. So the babies that are born with this usually have an ASD and a VSD, which allows the blood to mix. So they're getting some oxygenated blood to their system. This needs surgical correction right away. They literally switch the arteries. They will have a lot of long-term complications as adults, and they may also have RV dysfunction later on. This is also associated with AV conduction abnormalities. So, what is an AV conduction abnormality? What's that? Heart block, exactly. So, a lot of times you'll see associated heart block with these patients. So, I would definitely know that as well. Okay, so this is wild. This is congenitally corrected transposition of the great arteries. This is extremely rare, but this is when the arteries are in the wrong spot, but the body has flipped which side is oxygenated and which side is deoxygenated. So they're right, the pulmonary artery is acting as like the aorta, and the aorta is acting as the pulmonary artery because the right side is serving as if it was the left side with oxygenated blood. So the circulation actually switched. This is extremely rare. So it's the same thing as transposition of the great artery. So it's flipped, but somehow congenitally, the body corrects itself and it just makes the right side of the heart the oxygenated side and the left side of the heart the deoxygenated side. The problem with this is it can cause, well, there's a lot of problems with it. The whole thing's flipped, but it can cause RV failure because the right side of the heart isn't designed to hold that amount of pressure for a long period of time, right? Usually it's oxygenated blood. It's designed for a lower pressure state. So you can get right heart failure and RVH. Next we have, which is more rare, partial anomalous pulmonary venous return. So this is a defect that's present when one or more pulmonary veins drains into the right side of the heart instead of the left side. Usually from the right lung, the pulmonary veins, wait, what did I say? Hold on. Usually from the right lung. Okay, so usually this will arise from the right lung into and dump into the superior vena cava or the IVC or the right atria or the coronary sinus, which is the vein that wraps around the left side of the heart and the right side of the heart. There can be a variable amount of left to right shunting. If this is if obstructed total anomalous pulmonary vein, this needs to be corrected immediately at birth. So partially means that there's still some flow from a pulmonary vein going to the correct location. Obstructed total anomalous pulmonary vein means that all of the pulmonary veins are dumping into the right side of the heart, which is a problem. The pulmonary veins go back to the left side of the heart with the oxygenated blood. So if those are all dumping into the right side of the heart, that needs to be corrected at birth, and that will be a more severe case than partial anomalous. So partial is some of the pulmonary veins are going back to the left, but some of them are going to the right. So this will have some element of cyanosis at birth. If it's all of the pulmonary veins going to the right side, not compatible with life, needs surgical correction immediately. Then we have something called Epstein's anomaly. This is characterized by a deformity of the tricuspid valve. This is when you have apical displacement of the septal and posterior leaflets, and they adhere to the RV wall. So it's basically no tricuspid valve. 80 to 90% will also have an intra-arterial shunt. And 25 to 30% will have WPW. So what are the characteristics of WPW?
Reentry circuit.
Reentry circuit, delta wave with wide QRS, short PR, exactly. Short PR, widen QRS with the delta wave, reentry circuit via the bundle of Ken. So that's a genetic association as well. This will have cyanosis early in life. They will have CHF in adulthood. They could have arrhythmias, like we said, shortness of breath, and decreased exercise tolerance, depending on the severity of this. We diagnose this with an echo and a right heart cath, similar to all the other congenital lesions that we've talked about. And then we have, again, mild cases, no treatment. Severe cases, they get a surgical cone procedure, which kind of grafts them like a brand new tricuspid valve to be functional. So tricuspid atresia is a congenital defect characterized by the absence of connection between the right atrium and the right ventricle. So the tricuspid valve basically isn't there, and the RV is hypoplastic. And the inflow portion of the RV is also absent. So adult survivor, you can't survive this unless it's surgically corrected. They will sometimes have a PFO like you see here. This is the right ventricle. And when you look for this, you're also going to look for communications and other congenital abnormalities like the PFO or the VSD. This one is very rare and will definitely need surgical correction. This is a cyanotic lesion. They can present with CHF. The EKG might show diminished right precordial forces. So when we say diminished right precordial forces, what leads on the EKG are we talking about?
V1, V2, V3.
Yes, exactly. So if you think about lead placement, guys, just to reiterate, the precordial leads, V1 starts here, V6 starts here. So the right side is going to be V1 to V3, and then V3 to V6 will be the left side precordial lead. So they may have like very small right precordial QRS complexes with LVH at birth. And that makes sense because there's basically nothing happening in the RV, and then the LV gets enlarged because it's working extra hard. Diagnosis, echo and cath. The treatment is surgical correction. So pulmonary atresia, the pulmonary valve is gone. And all the blood flow is through the PDA. It will have cyanosis at birth that gets worse. So the ductus arteriosus can take a little bit of time to close after birth, right? So once that closes, that communication, the cyanosis will get worse. So you can give prostaglandins to try to keep the ductus arteriosus open longer while they wait for surgery. This requires a big stage surgical procedure depending on the exact variation in anatomy. Hypoplastic left heart syndrome is exactly what it sounds like. There's a very, very small non-functional LV, which is a big problem. Cyanotic at birth and also needs staged procedures. The Norwood procedure, they get a first few weeks of life, then they get a bidirectional Glenn shunt procedure at 6 months, and a Fontaine procedure at 18 months. That's a really big surgery. I don't expect you guys to know the details of those. Once complete oxygen-rich and oxygen-poor blood no longer mixing, the infant is no longer cyanotic, and that's the correction. Truncus arteriosus. This is when the truncus arteriosus fails to form into a pulmonary trunk, and the aorta remains a single vessel. So there's no distinction between the pulmonary artery and the aorta. It's just one. You can see it here. The truncus, it didn't divide, so it's just one large vessel accepting bloods from both sides. So we have a cyanotic lesion. The symptoms will appear after the first few days of life. This requires surgical correction as well. And this is basically the Rastelli repair with a patch septum, a new pulmonary valve and artery is made. Okay, so those were all the cyanotic lesions. To summarize, there is some type of right to left shunting in all of those lesions that we talked about. So there will be cyanosis, whether that's immediately for some of them or early in the neonatal period. Some of them, if they're small, you can leave them alone. Most of them need to be surgically corrected to fix the cyanotic mixing of the blood. And those are the patients that are going to be followed by pediatric cardiology for their whole lives. Now we're going to get into some other congenital abnormalities outside of the cyanotic, acyanotic lesions. There's certain type of maternal and fetal factors that can make a fetus susceptible to having congenital AV block at birth. This could be observed in complex congenital cardiac anomalies, such as transposition of the great arteries, which we saw already. Also, it's sometimes seen associated with ASD and VSD. If the heart is structurally normal, a lot of times the mother of the baby may have an autoimmune disease, or had some type of viral infection, or was on drugs that are contraindicated to cause this. There is also something we're going to talk about called anomalous coronary arteries. And this is when the coronary arteries arise in a spot that they're not supposed to arise from. So normally the coronary anatomy, as we know, they come the two main coronary arteries, the RCA and then the left main that branches into the LAD and the circumflex, should arise in certain locations off of the aorta. So the RCA should arise from the right aortic sinus, and the left main should originate off of the left aortic sinus. And you could see that visualized here. You guys do not have to memorize every single one of these. This is just a visual to show you how many possibilities, how many like genetic variations people can have in their coronary anatomy. These are called anomalous coronary arteries. So normal for reference over here, we have the pulmonary artery and the aorta, and then we have the RCA off the right sinus and the left main off the left. So there's some lower risk lesions. The ones that I want you guys to be familiar with are the higher risk ones. So the higher risk lesions are when the LAD or all of the left circulation arises from the right cusp of the aorta. And the reason why it can cause a lot of problems is because with exertion, this coronary artery can get squished between the aorta and the pulmonary artery. So it can cause almost like an MI if someone is exerting themselves. And I think there was a famous basketball player who had this. And I forget, I'm so bad with names, but this can cause sudden cardiac death because it could be like an MI if this is if it occludes all the blood flow to the left side because of this, and someone's really pushing themselves and they don't know that they have this, this is usually found like incidentally. Like it doesn't usually cause symptoms until someone's like really exerting themselves or they get a test to evaluate the coronary arteries for another reason. Like we would see this sometimes if we ordered a CAT scan of the coronary arteries for a different reason, and it would read anomalous RCA. But the high risk ones do have to be surgically corrected. And of course, these are like not good. If they come off of the pulmonary artery, if any of them come off the pulmonary artery, that needs to be corrected. Or if it arises from if the left arises from the right side, it can be compressed between the pulmonary artery and aorta during vigorous exercise. And then down here is something called myocardial bridging. You know how we talked about most coronary arteries, the large ones should sit on top of the epicardial space, like on top of the artery. Myocardial bridging is when the artery actually dips into the myocardium and then comes back out. So with systole, this artery is compressed and there's restricted blood flow. We already chatted about this. Okay, we chatted about this. So the most high risk one is left coronary artery between the aorta pulmonary artery or originating off the pulmonary artery. They may show signs of ischemia at 2 months old with these. The other ones may show up incidentally, like we said. Right coronary artery arising from the location between the aorta and the pulmonary artery can also cause ischemia during exercise and result in sudden cardiac death. So anything between the aorta pulmonary artery we don't like. Okay, dextrocardia. This is a pretty wild one. This is when the heart is positioned on the right side of the chest instead of the left side. Sometimes this is associated with something called sinus inversus, where all the organs are reversed. I actually saw that my first year as a PA. And usually it was the patient who like never saw any type of medical specialist or anything. And he came into the hospital and we got a chest x-ray and everyone was freaking out because he had dextrocardia and sinus inversus. So all of his organs were flipped on the other side. So this could be asymptomatic and found on routine EKG or chest x-ray. So on EKG, the leads are going to be reversed, right? So to get an EKG on them, you have to put the precordial leads on the other side. And everything's going to be flipped. So you're going to have positive QRS and AVR V1. You're going to have a negative P wave. You're going to have an R wave in lead one. So everything's going to be reversed. And this is also, I don't know if anyone watches Grey's Anatomy still, but there's an episode where someone comes in and there's a gunshot wound to the chest and he lives and they're like, he has dextrocardia. It was on the left side, but his heart's on the right side and then he lives. So that's another way to remember it.
Would you switch the lymph leads too?
Yes, you would. It would probably still look a little different on the EKG either way. Like it wouldn't look like a normal EKG just by how it's going to see the heart. But that's a great question. I'm not totally sure because I've only seen that one case. But in theory, I imagine you would need to flip the limb leads too. You need to flip everything. But I'm going to put a pin in that and get back to you. Congenital heart disease is really associated with a lot of genetic abnormalities. So Down syndrome, there's a 40% incidence that they're going to have an ASD, a VSD, or a PDA at birth. With Turner syndrome, like we said already, it's associated with coarctation of the aorta and a bicuspid aortic valve. DeGeorge syndrome, which is microdeletion of chromosome 22, is associated with tetralogy of Fallot and truncus arteriosus. And connective tissue disorders like Marfan syndrome, Ehlers-Danlos, familial thoracic aortic aneurysm, and Loeys-Dietz syndrome. These are all, when you think of connective tissue disorders, think of everything stretching. So they're associated with like mitral regurgitation, aortic regurgitation, aneurysms, things like that. Marfan syndrome, this is a disproportionately, you guys have heard Marfan syndrome already before. So tall structure, joint ligament laxity, arachnodactyly, retinal detachment, subluxated lens, aortic root, and they are more predisposed to dissection and aortic insufficiency, and also mitral valve prolapse. So these are things we're looking for on physical exam as well. Ehlers-Danlos syndrome, this is genetic, shares several characteristics of soft, hyperextensible skin, abnormal wound healing, easy bruising, and joint hypermobility. These patients, we monitor for mitral regurgitation and aortic root dilation, like very early and aggressively, because they're prone to aortic aneurysms and mitral regurgitation. For familial thoracic aortic aneurysms, 1 in 5 people that have aortic aneurysms have a genetic history of aortic aneurysms. And these people need to be screened every 3 to 5 years to monitor and prevent dissection. If you see, like when you're checking them every 3 to 5 years and it's stable, you can keep it at every 3 to 5 years. If you check it and you see that it has increased a certain amount, you're probably going to check it every 6 months to a year once it gets over a certain size. Loeys-Dietz syndrome, this is an autosomal dominant genetic disorder. Think widespread aneurysms everywhere. They're going to have wide space eyes, a bifid uvula or a cleft palate. PD lab exam coming in handy. We're inspecting the soft palate. We are looking at the uvula, having them say ah, because we're looking for a bifid uvula and a cleft palate in these patients. Aneurysms and aortic tortuosity, so twisting of the aorta. There's been big advancements in maternal fetal medicine and in utero operations, which is very, very remarkable. And people are doing a lot better than they used to with the same type of congenital issues, which is amazing. Okay, lastly, we have pulmonary hypertension. We sort of touched upon this. Pulmonary hypertension specifically is defined as we have hypertension in the pulmonary arteries. Specifically, we measure this as over 20 millimeters of mercury with pulmonary vascular resistance over 2 Wood units. And that is something measured on a right heart cath. There's 5 groups based on etiology. So before we get into the 5 groups, you guys have heard of pulm, you covered this already in pulm?
Okay,
oh my God, we're like same.
Too.
Oh, is that right?
Yeah, we have the same chart.
Oh my God.
Yeah.
Oh my God, all right, we're aligned. So, oh, that's so nice, I love that.
Yes.
Okay, perfect.
Studying that for a test.
Oh, I love that. Oh, you just had it on it?
Yeah.
Great. Okay, so this is just like, you guys know this already. So the pulmonary arteries are going to constrict because of chronic high pressures in the right side. So, all right, you guys tell me, group 1, how do we treat it?
Oh, we didn't.
So we didn't have that. You're not wrong. Yes, you're right. So, okay. So group 1 is if there's no other reason for pulmonary hypertension, is group 1. If it's genetic, if it's drug-induced, if it's connective tissue disease associated or congenital heart disease associated pulmonary arterial hypertension. So that, well, we'll talk about treatment after. Group 2 is due to left heart disease. Risk factors for this include coronary artery disease, hypertension, diabetes, high cholesterol. So think of group 2 as CAD patients with left heart disease. Group 3, think of lung disease causing it. So this is from chronic hypoxia or chronic lung disease. Think like end-stage COPD, end-stage interstitial pulmonary fibrosis, or severe sleep apnea that's untreated. Group 4 is chronic thromboembolic pulmonary hypertension. So people are just throwing PEs and it's causing hypertension. And I know you guys have definitely covered like big, huge single PEs or saddle emboli. There's also like certain patients that have hypercoagulable states that can cause shower emboli of PEs. So these are like small chronic distal emboli in the pulmonary vasculature, and that can cause pulmonary hypertension over time.
Yeah.
I don't think it's like as bad. They present differently. Like a acute PE will present, yes, it'll kill you. The shower emboli are more vague. They may have like chronic short of breath that's not as acute or in your face. Group 5 is everything that they didn't know what to do with. So this is miscellaneous. Think like complicated autoimmune sarcoidosis. Okay. So clinical presentation, it's gonna look like CHF. They're gonna have shortness of breath with exertion. They're gonna be fatigued. They're gonna have exertional chest pain sometimes, and they may have syncope from hypoxia. You need a left and right heart cath with special tests for diagnosis. So we need a left heart cath because we have to determine if it's from coronary artery disease. We need a right heart cath to check the pressures of the heart. And then there's a special test called a nitric oxide test where you give the patient nitric oxide and you see if it relieves their pulmonary hypertension. And usually that means it's pulmonary hypertension group 1 if it responds to that test. So from groups 2 to 5, you're going to treat their underlying cause. If it's from left heart failure, you're going to treat left heart failure. And trick question, how do we treat left heart failure? Diuretics, yes. What else? If the EF is less than 40.
I
Yes. What else? Yes. Yeah, GLP-1, that's not guideline directed, but they may benefit if they have obesity.
That whole thing.
Yep.
Oh,
Yes, the MR, that's in the MRA.
And then Jill looks for one of them. Oh my god.
Yeah, that was for, not for, that's not guideline directed, but I feel like it's going that way. Okay, so we treat the left heart failure, we treat the coronary artery disease. If they have COPD, we treat that. If they have, what else do they have? A PE, we treat that. And if they're miscellaneous, we find out what the miscellaneous is and we treat that. So for pulmonary arterial hypertension group 1, we do the special test on the right heart cath to see if it responds to nitric oxide. And then we use our phosphodiesterate inhibitors like sildenafil or Viagra. Do not use calcium channel blockers if they have signs of CHF. It'll cause them to decompensate. You can also use prostacyclin analogs. But the thing I want you to remember is group 1, we ruled out any other causes. We did a right heart cath with the special nitric oxide test. It was positive. And now we're going to try phosphodiesterate inhibitors. These patients with pulmonary hypertension, they're extremely tenuous and difficult to treat. The mortality rate is usually very, very high. Like as we saw in the different classes, they have left heart disease, they start having right-sided pressure changes or remodeling, it's kind of heading towards our stage D heart failure, and they're very tenuous to treat. Like you treat them with diuretics, but they don't like their pressure too low, or you try to put them on guideline-directed medical therapy, that lowers their pressure too, and it's a very fine balance. And same thing, if it's group 3, they probably have end stage fibrosis of the lungs on oxygen and pulmonary hypertension. They're going to be very, very sick. So pulmonary hypertension is not great. Know the groups, know the treatment for group 1, and know the categories and treatment for all the other groups. You treat the underlying cause. And that's it.
Thank you.
You're welcome, guys.